with this, we'll go to our last presentation. Will be presented by Dr. Abdullah Alsaiedi, an interventional cardiologist and head of cardiology in National Guard Hospital in Jeddah, with the name of Navigating the Unexpected During TAVR. So he will present to us this case.
Assalamu alaikum, good afternoon. I'm going to present Navigating the Unexpected During TAVR. I have no disclosure, but I have to say I'm really feeling glad and at the same time feeling a bit nervous to present the TAVI complication case in a session shared by Dr. Mohammed Al-Ataibi. However, a good thing that Dr. Faisal Kofi, one of my mentors during training, is in the panelist. So 79-year-old male known to have type 2 diabetes, hypertension, ischemic heart disease, previous PCI more than 15 years, with heart failure, reduced ejection fraction 25%, post-ICD insertion. He complained of dyspnea and exertion. So in his echocardiogram, basically you can appreciate a restricted motion of the aortic valve with poor LV function as well as ICD. So we went ahead and did angiogram, showed patent stent in the mid-to-proximal LAD with no other vascular abnormalities. We did an FFR to that mid-segment LAD lesion. Basically, it showed FFR of 0.85, so no major concerns from coronary artery disease point of view. So cardiac CT angiogram basically showed a very large area, annulus area with the area of around 648 with a parameter of 90. So we're dealing with large annular valve. LVOT measurement showed no major discrepancy between the LVOT and the annulus area. Regarding the sinus of Valsalva and STJ, both were generous. If you look to basically heights in both right and left were actually appropriate for TAVI. Looking also to the accesses were sufficient to go and proceed with TAVI. And also, if you could appreciate, there was a calcification as well as penetrating ulcer involving the descending part of aorta. It was non-complex and non-symptomatic, so the decision was to treat that medically and proceed for TAVI. Now, our choice in this case, considering the poor LV function, to go with Navitor, the Vision, size 35 is the largest size from this valve. We went ahead to do the procedure. It wasn't straightforward TAVI because during deployment of the valve, we have to recapture 3 times actually. Every time we try to deploy the valve basically dig deep in the LV. So multiple attempts, and what happened actually during the last attempt, when we tried to retrieve the valve in the sheath, the last part of the valve basically wasn't able to retrieve inside the sheath. So with multiple attempts, milking the delivery system, we managed to push or to pull the valve all the way to descending, then all the way outside the body of the patient. And then we have to check the valve again. There is no major technical problems. Test it outside and reintroduce the valve again. And this time, actually, we have to use pacing in this type of valve, although it's not required by the company. But anyway, we managed to basically deploy the valve with excellent result. No paravalvular leak, gradient of 0 with narrow sinus rhythm. At this stage, the patient starts to complain of chest pain. Now, blood pressure is okay, 145, 190, heart rate is 90, saturation well through male with no new ECG changes. And if you take a look to the previous image, you could assess that coronary accesses on both sides were good. So at this stage, we basically scratch our heads and thinking what could happen. And we thought probably it's worth, with the history of penetrating ulcer, to do aortic angiogram. And you can see what happened here.
Section.
So there is a clear extravasation, partly in the descending aorta to the aortic arch at the site of penetrating ulcers. And if you could look to the right image here, there is a dissection flap involving that area. So at this stage, what you're going to do? Are you going to treat this patient conservatively, lower blood pressure and reserve, call cardiovascular surgery and vascular teams, or just consider TAVR? Yeah, because we are in structural lecture, right?
No, the surgeon will yell at you.
So, in these patients, consideration of TAVR based basically because we have a landing zone enough to deploy basically the TAVR device before the left subclavian artery. Considering his age, his comorbidities, and his prohibitive risk of surgery, we went ahead, and fortunately the patient was hemodynamically stable, so we took our time to do our measurement in his case. So in these cases, usually based on diameter, and we try to upsize basically by 15 to 20% to achieve a good basically expansion and sealing of the endograft. So we exchanged a wire, and basically we used the stiffer wire. We went with the Linder pressed, and our guidance is basically the big tail from the right radial artery axis. So under slow basically and controlled release of the valve, you could appreciate that we start usually by release the crown from the endograft. We use in this case Valiant thoracic scintigraph from Medtronic size 34 millimeter. And slowly, basically, the first steps under control, basically release of the valve from the sheath. We managed basically to put the valve, the endograft in descending and basically aortic arch with excellent results. So the patient hemodynamically stable throughout both procedures, kept in the CCU 24 hours, then was discharged home in stable condition. So I'm going to give one slide about the aortic dissection after TAVR. The incidence basically is similar to any cardiac catheterization, very rare. It depends on the literature, from 1 per 1,000 to 2%. It's constituted 10% of the emergency surgical conversion during TAVR. Mortality, very high mortality, 50%. When we talk about type A and type B, type A more common, usually 3 to 1 compared to type B. Both actually balloon expandable, self-expandable, responsible equal percentage for all type of aortic dissection. And you can look here in the right scan, risk factor aortic aneurysm, older devices, bicuspid aortic valve, atherosclerosis, and female. So my take-home message is rare complications, carries high mortality, meticulous and careful advancement and retrieval of TAVI gears is very important. Early recognition and prompt management is crucial. When we talk about conservative versus TAVR and surgical options, depends on the patient age, type of aortic dissection, and surgical risks. Thank you.
Thank you very much, Dr. Abdullah. I think we are already 30 minutes of our time, so we'll allow our panelists to comment on Dr. Abdullah's specific case and in the whole complication session. So we'll start with Dr. Mohammed Atawi.
Brilliant. And I like the idea that you didn't lose your wire, which is in the LV in case of disaster. This is your sailway. Yeah, if you have any issue, don't lose the wire in the LV. It's your sailway for everything, for the valve, TFR, anything. So brilliant, brilliant work.
Thank you. Dr. Zakaria.
Maybe I'm not interventionist, but I will never thought about it. So thank you for bringing up that complication.
Dr. Talal.
Great save. I mean, it's a very rare complication. We don't see it that often, but that's tell you that you have to be very careful advancing and retrieving your delivery system.
Great save, Abdullah, well done. I have to say there are some cases where they manage conservatively.
Thank you.
Yes. Thank you very much, Dr. Abdullah. It was a great session. Complications always needed, and we need to learn from our mistake. And I think it's a lot of cases have been presented, suicidal LV by Dr. Abdurrahman, and we learned from it that pulmonary hypertension is something that we have to be worried about, and it's be careful and watch it because it can lead to an LV problem. Basilica unicorn TAVR from Dr. Tayyib Yusuf. The message here, it's interventional cardiology is not only going for only 1 hour procedure, you can go for 9 hours procedure. It's very, very difficult. And the other message is it's not, there is always somebody can do something extra. So if you feel your patient that reached the limit that there is no procedure can be done, we connect together. And I think GIS working in creating a platform that connect all the interventional cardiology in the region for a daily chat and sharing cases and have experience. So you're going to see it soon. A case from Qatar, femoral access. It was a well demonstration. I think the message here is when to stop and ask for help, and maybe an extra tools that can damage more than help. Late sinus sequestration. I think we have 2 messages here. The first one was try to prevent it before it happening by doing the CT measurement and appropriate sizing. And if it happens, there is always demonstration of the balloon to the sinus that you can create some channel. And BVL low-seated valve by Salim Asiri, I think you make all happy by the way you handle the case and was patient-centered approach, and really thank you very much for doing that. And the last case of Dr. Abdullah Alsaiedi, it's a great, safe, structural and peripheral approach, well done. Thank you very much. I will leave to the end to the Dr. Mohammed Mokhini to conclude the session.
Thank you very much. Actually, all of us will learn from the cases presented. I like the discussion among the audience and the interaction. So we'll close the session. Bye. And thank you all for staying late for the day.
Thank you.